And the aim today is to go through intravascular ultrasound. And we want to try and make this as interactive as possible. So if you've got any questions, anything you don't understand, just stick up your hands or just speak out. And we'll try and, if we can, answer any questions. So I'm joined by my co-chair here.
For Jalisi.
Dr. Jalisi, yes. Apologies. First we'll do is we'll talk about the basics of IVUS. Now I've got some clinical cases that we can discuss about the utility of IVUS, and then we'll have a hands-on practical session like we did on the rotablation on the IVUS console, sort of how to set it up and the practicalities of that. Okay, so how does this work? Gotcha, thank you. Still not working. Next slide, please. Next slide. Okay, so this is the objective. So what we want to do is for you to be able to identify the 3 layers of the coronary artery. So remember, intima, media, adventitia, and then understand, back 1 slide, please. Understand the plaque characteristics from the IVUS images, precisely measure vessel and lumen diameter and make an assessment of the plaque area and also lesion length, and then decide on stenting, appropriate stenting size. Next slide, please. Okay, so we know that there are limitations of invasive angiography. So essentially what we're doing with invasive angiogram is looking at what is a 3D structure on 2D imaging. And as a result, if you look at this LED on the face of it, most of you will probably say this looks normal. Yeah. So this is you would pass off as an unobstructed coronary artery. Now it's only when you put your IVUS catheter down that you can appreciate actually the vessel's not normal. What you've got is extensive plaque. So this is what we're seeing here, extensive plaque within the coronary vessel. Okay. So we know that IVUS can be useful, and it has a higher resolution than angiography, and this is why we use it. Next slide, please. Okay, so how does ultrasound work? So the ultrasound probe that you will see in a while basically sends out high frequency sound waves. So remember, your normal hearing is between 20 and 20,000 hertz, and anything more than 20,000 hertz is ultrasound. Okay, so you and I can't hear ultrasound. Our ears are not tuned to hear ultrasound frequencies, but certain animals can. And usually what we tend to use for ultrasound in medical practice is sort of 20, 40 or 60 megahertz, right? So what happens is this probe is passed and it sends out the ultrasound signals, but it also acts as a receiver as well. So those signals are sent out, generates echo noise, comes back to the transducer, which is a receiver, and that picks it up, and it gives you this sort of black and white cross-sectional image of the coronary artery. Next slide, please. Okay, so if you look at a normal coronary artery, you'll remember back from earlier days, the vessel basically consists of a trilaminar structure. So you've got your intima, you've got your smooth muscle cells, which is made up here of the media, and then you've got your deeper tissues, which is your adventitia. Now, the actual media itself obviously has an internal and external elastic membrane. That's important to know about, because this is what we use on the IVUS to do our measurements. Now, when you compare that to what's going on an ultrasound, and this is an enlarged picture of that, the media will appear black. So the smooth muscle cells don't reflect IVUS, they absorb the ultrasound and therefore will appear black. And that's the first thing that you want to look out for when you're doing the IVUS, because as soon as you've identified where the media is, you can then determine anything inside of that is going to be your intimal lining and your plaque. Anything beyond that is going to be your adventitia. Yeah. Next slide, please. And this is what it looks like. So I've marked out here. So you will normally have your dropout because of the IVUS catheter, and that's seen here in the middle. The dark black layer is your media, and then anything above and beyond that, the fibrotic tissue, is your adventitia. Next slide, please. So just go back a slide. Back, yeah, okay. So here I've marked out the media, and it's important for you to be able to do that visually when you look at the IVUS. Okay. Next slide, please. So, of course, very rare for you to put an IVUS catheter down and find a normal coronary artery. What you will normally find is disease in the vessel, because you wouldn't be doing the IVUS in the first place. So here, next slide, please. Next slide, please. So here, what I've done is I've marked out the media here for you, which is the yellow line. So anything on the inside of that is then disease, okay? And here's the lumen that's been marked out. So you can see there's quite extensive plaque disease in this coronary artery, okay? So the first thing, whenever you see an IVUS picture, always try and identify the media, okay? And that's your starting point. Next slide, please. And then at that stage, you then decide, okay, I've identified that there's disease here, and you make a judgment on the type of plaque that you have visible. Right? So on the left here, what we've got is what we would call soft plaque or fibrofatty plaque. And what tends to happen in fibrofatty plaque is that it's usually of low echogenicity when we compare it to the adventitia. Right? So it's usually dark, and we're assuming here that there are lipid pools in here. Okay, so it would normally appear like a dark shadow within the lumen, or just abutting the lumen and away from the media. The other descriptors of plaque are fibrous plaque. So in fibrous plaque, what you tend to have is an intermediate echogenicity, and it's usually homogeneous, but of course you can get mixed plaque as well, so you can get fibrofatty and fibrous plaque at the same time, and indeed calcific plaque as well. So here, this is a similar echogenicity to the adventitia. So this is fibrous plaque, what we're seeing here. Okay, then these are still pictures, of course. And then on the extreme right is calcific plaque. So I don't know, a lot of you were already at the rota session that we ran just earlier. But here you can then make some judgment about the extent of calcification, and also whether it's superficial or deep. So can we go back? Back. Yeah. But yes, thank you. So here you can see calcium, remember, means that the ultrasound won't be able to penetrate through calcium, so you get this reflective appearance. So here you can say there's probably around a 200-degree arc of calcium in this vessel. There's calcium here as well. This is superficial calcium, so it's just abutting the lumen. If it were deeper calcium, it would be in the deeper layers. Now, there might be deeper calcium here as well, but we can't tell because the ultrasound won't be able to penetrate through calcium. So you can't tell the thickness of the calcium based on what we're seeing here. Next slide, please. So here's a slide which hopefully will maybe able to answer some of the questions that you had in the previous session. So here, can you see, here you've got plaque here, but this calcium is deep. It's beyond the plaque. So this is deep calcium. And this is the schematic of that. And that's very different to superficial calcium as we just saw on the previous slide, but here's another example. And here you can say there's superficial calcium, it's probably bound, maybe 280, 290 degrees. Okay, so you just make a judgment on the degrees. The other thing you can do is sort of talk about quadrants, so you can talk about affecting 3 quadrants or 4 quadrants. So that you might hear that described as well when people are talking about IVUS. And here what you've got is superficial and what we call concentric calcium. So it's going all the way around the lumen here. Right? So this is superficial and concentric calcification. Now earlier I referred to reverberation artifacts, do you remember, in the previous session? And this is what we're seeing here. So this is the reflection of the reverberation. It's sort of an echo of the echo, if you like. And when you see reverberation, it usually means that the calcium is actually thin. It's not thick calcium. Right? So it's an important thing to pick up on the IVUS. So you can get some clues on IVUS about the thickness of the calcium. Next slide, please. Okay, so that's plaque covered, right? So there are obviously lots of other things that can be seen on IVUS as well. So on the IVUS, and one thing I didn't mention is these are millimeter markers. So you can make a judgment about the size of the vessel or approximate size of the vessel looking at the markers. So anyone want to tell me what they think the size of the vessel is here on the left-hand side? Yeah. So the way to do it is just to roughly look at how many of these markers are present. So 1 millimeter, 2, 3, 4, 5, 6, 7. So 7 millimeters probably in diameter. Yeah. So it's a large vessel. It's an aneurysmal vessel. Yeah, because your coronary arteries aren't usually that sort of size. So here. And this is actually probably better seen on moving images. These are still images, but you can see there's a mass here within the lumen of the vessel here, and this is a filling defect in an aneurysmal vessel. It's most likely to be thrombus. Okay. Again, dissections are not very well seen on still images, but if you've got a dissection, it's on a moving image, you'll usually see it sort of flapping away at you. I do have the video of this later on in this series of cases, so we'll see this live as well. So you can sometimes pick up dissection. So this was an edge dissection. There was a stent that was put into the artery, and this was left at the end. And then occasionally you might see other weird and wonderful things as well. So you remember the SCAD talk I gave yesterday, and this is the IVUS picture of a lady who had actually a left mainstem SCAD. So if you identify the media here, remember the media is black. Can you see here? This is the media. So whatever this process is, it's occurring outside of the media. So it's separating the adventitia and media. So this is a tear going all the way around, circumferential tear down the vessel. So this is a SCAD case. Very rare to see this. So it's the dark band. So here, can you see here? This dark band. And remember that the depth of IVUS, is around 10 millimeters. So if you've got a big aneurysmal artery, sometimes it might drop off. So you don't see the vessel here, but you can appreciate here the dark band. Can you see that? As I move here, this is the dark band. Can you see my green pointer? That's the media. Yeah. In the middle one, it's a bit more tricky to see, but it's here. just going around. And then this is plaque inside the vessel. So anything inside the media then is the intima. Intima isn't picked up on IVUS because the resolution of IVUS is not high enough. But anything you can surmise is inside of that is your plaque. Next slide, please. Okay, so the most basic measurements that you can make are to determine this vessel diameter and your lumen diameter. Okay, so this is one of the most basic measurements that can be made on IVUS. Now, when you're doing the vessel diameter, and this is where the earlier slide is important, what you want to do is to measure from the leading edge to the leading edge. So external elastic membrane, which is the outer portion of the media, to the external elastic membrane outer portion at the other end. Okay, and that's shown. I've tried to depict that here with this yellow arrow. So it's from EEM to EEM. And you can make 2 or 3 measurements. And of course, if you've got aneurysmal vessel, then you're not going to have a complete circle. So your diameter might vary depending on which angle you're crossing your circle or your vessel in. And you can do the same for the lumen as well. So on a moving image, this is a little bit easier, but you can make out the plaque here. And there's a little bit of plaque up here as well, so you can make a lumen diameter measurement as well. And why is this important? Because this will help you for your stent sizing, which we'll come on to a bit later. Next slide, please. Can I have the next slide, please? Thank you. Okay, so that's your basic measurements. The other measurement that's important, and this can be automated on the devices, is the cross-sectional area. Okay, so once you've got your lesion, which is present, you mark out your EEM, which is the blue line here. Okay, so that's where you see the dark band. You mark it out is the EEM, and that will give you an area shown here in the blue. Yeah, that corresponds to that. That's your external elastic membrane area. You can also do the same for the lumen area. So these measurements can be either automated on the device or they can be sort of put in by dropping dots into the lumen. And you can get a luminal area, which is 3.63. Now, using those measurements, you can do some basic maths to work out what your plaque burden is. Next slide, please. So I've marked out here, so it's the same slide as previous, but I've marked out here in the yellow the plaque burden here. Okay. Now there's an equation for that. So the plaque burden is basically your EEM area, subtract your lumen area, divide by your EEM area, and multiply by 100. And as I say, normally it will just be automated, so it will just come up and it will say 66% plaque burden on your device. Okay, so this is where the plaque burden comes from, and when people talk about 50% left main stem disease, they're talking about plaque burden in that situation. Now, plaque burden is different from area stenosis. So your area stenosis, and you can see the 2 numbers are different here. Can we just go back to the slide? So the 2 numbers are different. And the area stenosis, just go back, please. Yeah. Area stenosis is done in reference to a normal segment of vessel. Right. So, and these 2 things are not the same. Now, they might be similar, but area stenosis is a separate defined parameter. Okay, good. So that's the basics. Next slide. Any questions on that? Yeah. Can you talk into this mic?
this area of stenosis, which is calculated, do we have to set the parameters for it, defining to the machine that what is the normal vessel, or is it some algorithm to which it is being equated against?
Yeah, so that's a very good question. And actually, yes, you do have to. You have to mark out on the machine what your reference is. And you've got a button that you can press, which then equates everything to that referenced area. Yeah. And when you're referencing, what you want to do is to find a relatively healthy segment of vessel within about 4 or 5 millimeters of the disease segment to then work out what your area of stenosis is. Now, that might not always be possible if you've got diffuse disease, in which case you try and find the best segment, which is the least unhealthiest, if you like, to be able to do that. But we'll show you that when we get onto the practical session.
If there is a heavy calcification of the vessel, so because the ultrasound waves cannot pass beyond the calcium, we can't see anything beyond it. So how do we calculate the area of the vessel and the plaque burden?
Yeah, again, a very good question. You can't basically, because to calculate the plaque burden, you have to be able to see your media. Yeah, so you can't in that situation. All you can do is calculate lumen size. Okay, so should we do some cases, sort of practical cases, and then we can move on to some. Is that?
Yeah, just speaking to. So just a couple of things that I think we just went over. One of the things is getting a good spot where you'll get a normal reference, right? If you don't have a normal reference, all your calculations will go out. So getting a normal reference is also very important. The second thing is that you want to be, when you're measuring, you want to take some time. I've often seen that people are scrubbed and they ask other people to do the measurements, and the outline is done incorrectly, and then your answers come out incorrectly. The way I use IVUS is for two purposes. One is figuring out the area of stenosis, which I think is important for making some decisions. The second is I often use it actually more for figuring out the size of the vessel. When I'm trying to decide on stent sizing, balloon sizing, because what you don't want is to undersize your stent, right? That's the biggest fear, malapposition and stuff. And I also use my stent for going back, my IVUS for going back and figuring out if my stent that angiographically looks good is really good, right? So if you already have the IVUS out, there's certainly, it takes a couple of minutes to go in, and you'd be surprised how many times you'll see that your stent is well deployed angiographically when it's either undersized, underopened, and you can do better with just an NC balloon afterwards. So I think improving your strategies at PCI, if you already have the IVUS out there, there's room, especially if you're doing left main proximal vessel stenting. I think you should try and use IVUS for those things. I think we have physiological measurements of iFR and FFR that are that have their advantages, but I think IVUS, even though it's a slightly older technology, is still very useful in a lot of places in the cath lab. So do get good at it. Rely on your own measurements. Don't rely on somebody else in the lab to be measuring for you, because at the end of the day, you're the one making the decision. So we'll do some hands-on, and then we'll go from there.
Okay, so I'll try and juggle everything with 2 hands. So if I hit this, no, going back. Okay, so we've got some cases that we can talk through. So 66-year-old lady coming with an acute coronary syndrome. The right coronary artery looks pristine. I'll show you that in a second. And then she's got this lesion in the very proximal LAD. So what do people think? What would you do in your practice?
Practically, I will stent this, but I think this is a case of scared. Not at all. I will do the imaging first.
Well, you know, that, I mean, that's the point, isn't it? Because if I walk into a room and I'm wearing dark glasses, I'm not going to be able to see very well. Yeah. If I put on some spectacles, I might be able to see better. That's your angiogram spectacles. But if you put on magnifying glasses, then you'll see even better. And that's where the IVUS comes in. The IVUS is kind of your magnifying glass. So on the angiogram, you know that there's a lesion there, but you're not quite sure what it is. And when you have diagnostic uncertainty, that's exactly when you're saying, well, actually, maybe I should be reaching for my IVUS catheter or some form of intracoronary imaging catheter to try and determine what's going on inside the vessel. So that, you know, there are a number of possibilities here. This could just be plaque disease, as you've said, or it could be a SCAD, but you don't know. And the management is going to be very different, isn't it? Because one of those you're going to want to treat with a stent, and one of those you're going to probably want to try and avoid stenting. Okay, so this was the right coronary artery, and you know the question is this atherosclerosis or not? And you can determine that quite easily by putting down your IVUS catheter. So these are some moving images. So just have a look at this. And so, you know, when you're coming back on the IVUS, remember the first thing you do is you identify this dark band, because that will tell you where the media is. And as soon as you've done that, anything inside of that is your plaque, and anything outside of that is your adventitia. Okay, so you can see here, this is Boston IVUS, so you will have a wire drop out as a result, and we're coming now into the proximal vessel here, which looks pretty normal, doesn't it? So I think the batteries have run out on this. So can we just go back a slide? Go back? Okay. And press play. Video. No. Go back 2 slides, please. Back. Forward. And it should pick up the video then. No. Back. Go forward now. Forward 2 slides, please. Yes. Okay. So hold that. Okay, so just try and get your eyes in on this. And what you'll appreciate, actually, that this is plaque. This is not a SCAD. Yeah. And this is this. What type of plaque is this then? On the classification that we showed earlier. Yeah, soft plaque. So fibrofatty soft plaque. Okay. And then the other thing you appreciate is the size of the vessel. You can see it's a large vessel. So you can use that information then to determine what size stent you're going to put into this artery, because you want to size it from your external elastic membrane to external elastic membrane. So when we worked out the area on the right-hand side, you can see 74% plaque burden here. So, you know, high volume of plaque in this vessel. So we were able then to determine what size stent to use here. So 4mm stent went into this artery, and we're quite comfortable doing that. Next slide, please. Now the very proximal segment here is bigger than that, isn't it? It's around 5.5mm. So if you look at the IVUS run, you can see the stent struts, which are evident now. And as we come back into this, you can see that it's abutting the plaque, but it can probably be pushed out further. Yeah. So what would we call that? think you were alluding to this.
Yeah, so I think this is very important, what we're alluding to. So the fact that it's touching the plaque means it's not malapposed, all right? A malapposition is stent thrombosis, right? And the other thing we're alluding to is undersized. And I think these terms you guys need to understand, okay? So if you're undersized, what happens? So you have a higher chance of restenosis. So I think understanding when you take a patient back and trying to figure out why did this guy have restenosis, why did this guy have stent thrombosis, I think IVUS plays a critical role in deciding what to do, right? Just don't go in and start ballooning. I mean, you want to restore flow first, but try and figure out why this patient is coming back to your lab. And I think IVUS becomes very important when anybody comes back as a second-time consumer as to what did I do wrong, what could I have done better next time. And I think IVUS teaches you. So both malapposition, which you would see with stent thrombosis, and undersizing. And I think undersizing is a big problem because angiographically, I think we undersize our eyes, undersize the vessels. Because we're always afraid we'll oversize it, we'll cause a perforation. So we're always trying to undersize, but we should all be able to take an NC balloon and expand it. And hope that restenosis will go down. So I think IVUS helps in both ways.
So actually here, it was abutting the plaque, so I was quite comfortable then to go in with a bigger balloon here. So I took a 6mm balloon and just opposed that to the vessel. Now you're looking at me thinking, wow, okay, but actually, I was comfortable doing that because I knew the size of the vessel, and if I didn't know the size of the vessel, I would probably have just dropped a 3.5 in this 66-year-old female. 4mm. Yeah, so you can grow your stents depending on the stent platform, and certainly the 3.5mm and 4mm stents will grow up to around 5.5, 5.7 millimeters.
So I think that's a very important question. Your drug delivery will get disrupted, and so every stent will have on it, if you look at it, the maximum diameter you should be going to. And actually, Zions came out with a warning at one point where you were oversizing your stent so much that you were disrupting the polymer and the drug eluting. So yes, I think that's an important question, and you should decide that up front. I still believe in really large stents still being bare metal. So if I'm going to 5+, I don't care about the drug as much as I do in smaller vessels. So if you're going to expand it up to 6+, think what kind of stent you want to use.
1 second.
Sir, in expanding this 4 mm stent to 6 mm, sir, won't there be a risk of stent fracture or the struts could be fractured?
Yeah. No, I think that's what we were sort of discussing. So there is a risk of possibly damaging the polymer on the stent. Yes. Oh, fracture. I've not seen that. Have you seen that going up with the big balloon? Yeah. Yeah. I mean, there's been lots of bench testing on these big stents, and they will go up. But you will obviously change the architecture of the stent as a result. Can I have the next slide, please? Okay, so that was the, no, go back. Yeah. Back. Okay, good. So this was the result after the 6mm balloon. So if you look at the IVUS, of course you're not going to get rid of the plaque. All you're going to do is push your stent out further, squash the plaque up against the vessel wall. And it's looking better now, isn't it? Certainly from an angiogram perspective and IVUS perspective. But actually, you could have left it as it was. Some operators would do that. I just felt that actually we need to open this out a bit.
So I think Sohail brings out a good point. You could have left it. And the reason is that the area that you calculate is also important. So as long as you wouldn't leave it if it's malopposed, okay? But if you have a 5 by, 5, so that's 25, right, at least. So you have a 5 centimeter diameter, you know you have really large lumen. And as long as you're well opposed, you could leave it. There's nothing wrong in that. You'll see it, as long as you understand that you've undersized it to the vessel, at 5 millimeters, you're not going to start getting restenosis significantly. So yeah, at smaller vessels, a different story, right? But remember, we have revascularization guidelines based just on areas of the lumen, right? So you got the 6 millimeter and the 4 millimeter. You're well beyond that. That's the 6 millimeter squared. Is when you start just thinking about left main revascularization, or 4 millimeters in the LAD. So yeah, see, these are all things that you learn as you start using the technology. If you don't use it, you'll never think about these things.
I think that's an important point, actually. If you're bringing out the technology at the time when you're not quite sure what's going on, then that's probably the wrong thing to do, because you need to familiarize yourself about how to set it up, etc. Okay, so shall we do maybe 1 or 2 more cases, and then we can do the practical. So 65-year-old gentleman, hopefully you'll all agree that he needs to go to the cath lab. He's got an anterior infarct. Next slide, please. So the right coronary artery looks a little bit tatty, but it's a dominant vessel. And the lesion here was in that proximal LAD. You can see that it's probably thrombotic. So what size stent are you going to put into this vessel? 4 millimeter? Proximal LAD, young man, yeah. Okay, not unreasonable suggestion. Next slide, please. So I put a 3.5 in here, and I went with a 20 millimeter length of stent. So that was put through, and what you can see and probably appreciate, slightly sluggish flow in that septal after that. What's going on? Yeah, slightly slow flow. Why do you think? Yeah, it could be thrombus that's moved on. Can I have the next slide, please? Yep. So it could be dissection. Yeah. So what happens then is you can see this guy's clutching his chest, and when you see that, it's always a bad sign. It means something is going on. He's getting chest pain. And my feeling was this was probably an edge dissection. So how are you going to treat that? Another stent, yeah. What size? 3 millimeter? Yep. Okay, next slide. So I took a 3 by 12. I thought, we'll just put an overlapping 3 by 12 stent in there. Next slide. That's the final result. Happy with that? I gave some integralin, Riapro, yeah, and he went back to coronary care unit. So I was quite happy. His STs had come down, his chest pain has settled at this stage. Next slide. Okay, so post-PCI, STs are down. 90 minutes later, my fellow rings me up. He's got chest pain again. What do you think's going on? Yes, stent thrombosis. Next slide. Next slide. So he's blocked his LAD. So I put a wire down there. So what's caused the stent to block? So under deployment of the second stent. Yeah, it could be that I haven't covered the edge dissection appropriately. Could be, yeah, it could be a intramural hematoma which is milked down. So there are a number of possibilities here. So how am I going to decide? Yes, good. You're in the right session. So, this is a prime example of where you'd want to use imaging catheter to try and work out what's going on. So have a look at the IVUS run. Yes. So it's quite obvious now. This was the earlier still that you saw. So you can see this sort of flap around sort of 6, 7 o'clock, sort of waving at you. That's the edge dissection. So there's obviously a tear in the artery, and this is coming into the stent. So it's just at the distal end of the stent. Yeah. So I'll just let that run again. If you look around 6 or 7 o'clock, you'll see there's a flap. So I've stented into plaque here, and as a result, that's caused an edge dissection, which I thought I'd covered, but clearly hadn't. So the treatment there is obviously, next slide please, is to put another stent in. And then after that, I repeated the IVUS to make sure that that I didn't have an edge dissection on that third stent that had gone in, because I didn't want a second complication.
Just a question to the audience. How would you, if you didn't have IVUS in your lab, what would you have done? So you have a patient comes back with stent thrombosis, same day, next day, whatever. You don't have IVUS in your lab, what would you do? You rewire, you restore flow, and what would you do? How do you know it's a dissection? It's in the middle of two stents. So you think it's undersized then? So what if you had sized it correctly and you now oversize it? Perforation, right? You don't want that. So I think this is a very good case to explain to you why you should have a properly equipped lab, okay? Poor man's way, you could do cine at 30 frames and see, but it's going to be very difficult between two stents to see if there's a flap. You can only say I had a gap, right? That's the only thing you can do at 30 frames. Say my two stents have a tiny gap, but you'll be guessing. So I think this plays really well into why you should be thinking when patients go back into the lab, what I was alluding to earlier. This is a great case. Thank you.
I mean, if you look at national databases, I'm sure it's probably the same in the US. In the UK, IVUS is used in about 10% of PCIs that we perform. In my practice, I use it probably in around 70% of cases, but I'm very much an outlier. But I think it offers a lot to my practice. And there's a lot of data now, particularly in left main stem, that we should probably be utilising it. Pretty much 100% of the time. So there is that cost implication as well. But I think one of the main barriers is probably the reason people don't use it, I think, is they don't always appreciate what they're seeing. So they're not quite sure what they're seeing and how to interpret the data. And this is where the training, I think, is really important, because you need to become comfortable seeing things on IVUS. I mean, it is unfortunately at the end of the day a black and white image, and you have to become comfortable with that so that you can appreciate what's going on from a pathological perspective. Next slide. Okay, so yeah, so here's a left main stem. So 66-year-old with left main stem, and of course, left main stems are challenging because is this significant? Is it not significant? He's obviously ended up on the cath lab table because he's been having some chest pain. So how can you make that assessment? So, I mean, you've got a couple of, you can image this, but you can do physiological assessments as well, couldn't you? Yeah, so you've got a couple of options in terms of what you might want to do. So, anyone with sort of a borderline left main stem stenosis, I tend to reach straight for the IVUS catheter or perform FFR. Next slide. So, guidelines suggest that we should be doing this as a 2A indication in the European guidelines. I'm sure that's the same in the American as well. Next slide. Okay, so that's what the IVUS probe actually looks like when you put it down on the right-hand side of the screen. And it's a motorized pullback, usually, unless you've got the volcano, in which case you can do sort of a hand pullback. But it allows you then to see the probe moving. Next slide. Okay, so there's lots of things that you can pick up when you look on IVUS, particularly for left main stem disease. So you can look at the type of and extent of the plaque that you've got, and that might help you determine the strategy that you're going to do for that bifurcation. So when you're doing left main stem IVUS, always IVUS from both limbs, so LAD to left main and also circumflex, because you want to look at the plaque burden at that bifurcation. And it will also, of course, tell you the size of the distal vessels, the daughter vessels as well, which will help determine what size stent you're going to put in. Next slide. So this is important. So if you do the IVUS run and your area is above 6 millimeters squared, then you're probably safe to leave that vessel alone. Yeah. And many people will say, well, actually, it looks worse than that. But actually, if you're at 6 millimeters squared, you're very safe to leave that vessel alone. You don't need to intervene on that vessel. Next slide. So here we are. So that's the vessel. This is ostial LAD. It's coming out at 5 millimeters. So pull back from the LAD into the left main stem. So just at that juncture from LAD to left main stem, the Titus area was 5 millimeters squared. So I think that then tells you that actually you do need to do something about this, and probably his chest pain that he's having is related to this severe stenosis that he's got in his distal left main stem. So what was interesting, I don't have the IVUS images of this, but when we did the pullback from the circ, there wasn't actually very much disease. There was mild atheroma in the ostium of that circ. So I felt that we could just do a crossover stent here. And this is where stent sizing becomes important, as we were discussing earlier. So I chose a stent that I know is going to be able to grow in that left main stem, because you want to do a proximal optimization of POT. Next slide. Okay, so that's what it looked like. So I re-IVUSed after the stent, and the areas are a lot better. And as we were talking about, what you're wanting to achieve is as maximum area as possible for the size of the vessel that you have. So in the left main stem, what you really want to do is try and get that as big as possible. And the reason for that is it reduces your risk of restenosis if you do that. So ideally, you want to achieve an area above 5.5 millimeters in a LAD or circumflex or right, and in the left main stem, anything above 10 is probably good. Next slide. Okay, good. Any questions on that case? I think what we'll do, shall we move to the practicals, and then, yeah. Do you want to gather around the console? Yeah, so what we've got here is Boston IVUS. Can we bring it out here, please? So this does not have ChromaFlow. Yes, so Volcano has a extra bit of software